Good morning. This is Dr. Moscato of Missouri Cancer Associates, and I wanted to talk today about AML, or acute myelogenous leukemia. Now, treatment decisions are made at the beginning because we have to decide how intensively should we treat this patient, or should we treat this patient at all. So what are the goals of therapy, potential benefits and risks? So we look at that, we look at age and prognostic factors. We have to look at family issues. Does this person have support? Are they older? How is that going to go? Obviously, these are very intensive therapies. You always want to ascertain the code status because these are very serious illnesses and know who the DPOA is, and spiritual care is very important. Palliative care consultation is often helpful and appropriate here since these are serious illnesses. Now, the treatment of AML is fairly standard. You'll hear us talk about 7 and 3, and that refers to 7 days of continuous infusion Ara-C and 3 days of bolus anthracycline, such as daunorubicin, idarubicin, or mitoxantrone. If remission is not obtained on day 15, on the day 15 marrow, we may give an additional 5 days of Ara-C and 2 days of anthracycline, or 5 and 2. You may see other inductions used, especially in research studies such as ADE, and reinduction, including drugs such as MEC or mitoxantrone, etoposide, and Ara-C. And in terms of the treatment, the 7 and 3 induction is begun. Obviously, nausea is an issue, and that has to be controlled. The white count usually begins to rapidly drop during the first 4 or 5 days, and the blast count should be gone. There should be no peripheral blasts usually by that time, and certainly by the end of the 7 days. If you still see blasts at that time, it's usually, in my experience, a fairly poor prognostic factor. However, I wouldn't necessarily emphasize all that to the patient since they're going through enough things, and we just have to say how it's going, and we'll see what the day 15 marrow looks like. We usually begin GCSF either right after the chemotherapy is done or after the day 15 marrow to see if it's hypoplastic, and there's usually some recovery of counts by day 21, but it can be delayed. The patient then can be readmitted 2 to 4 weeks later for consolidation chemotherapy, often with high-dose Ara-C, or they may go on for allogeneic transplantation. Now, IV access is clearly important, often a triple lumen catheter, irradiated blood products to avoid GVHD, routine transfusions of packed cells, often with hemoglobins less than 8, and platelet counts for less than 10 for single donor platelet transfusions. Some of the physicians write standing orders, and others will write individually, but that's the general principle. You have to watch the patient carefully for infection or bleeding, and of course the most tragic situation is a CNS hemorrhage, which is usually rapidly. Mouth care is important. Normal saline mouse rinses, Paradex is often used. Watch for thrush. Fevers are critical, but also watch the fever curve and let us know, especially if calling at night, if antibiotics have been changed during the daytime when infection was noted to be worse, because that's going to make a difference in terms of whether we change antibiotics again. Neutropenic and platelet precautions are universal. Skin care, constipation, and diarrhea should both be avoided, as one wants basically soft stools to avoid rectal irritation. Remember, in summary, that the life of these patients is in your hands. The mortality of induction is about 20%, but in the elderly may be as high as 50%. And basically, the survival is due to good nursing care, and I think that's extraordinarily important. So watch these patients carefully, be observant to their symptoms and their signs, be comforting to the patients, and oftentimes people make it through and are much better for it. So thank you very much. If you have any questions, you can always ask us, and I hope you enjoyed this slideshow.